one of the biggest questions that we now ask, or the most important questions that we now ask when we take our case history, which again was not something I did before, is what are you worried that your pain is? And people have got such an amazing worry about what their pain is. And that, if we can, often we can change that, because it's not true. It's a perceived fear. If we can change what they think it is, and this case actually that I'm going to talk about now, this lady was the same. She had a huge fear about her pain actually being caused by MS. And when we can change that, then the fear goes away and the nervous system regulates, and then essentially we can start to change that, and that will change the pain.
Right. Okay.
So she was a lady, she's got chronic neck pain, cervical spine pain that she's had since November 2019. She's 44 years old, and the onset of it was related to her job. She was a hairdresser, and she ran her own business, and she was really stressed in the year before her pain came on, because she'd got to sell the business and she'd had some trouble with her work colleagues. So her symptoms are also accompanied by, and I think this is something again that I wasn't necessarily looking at before I met SIRPA, is she didn't only have pain, she's got fatigue, she's got some dizziness, she's got some anxiety, she's experiences insomnia, she gets reflux, some irritable bowel, and actually for her a specific symptom is a problem with, she gets quite short of breath. And she, all these things together were making her obviously very, very anxious, and she is incredibly tight. She feels like a board. Literally, the muscles across her neck and into her shoulders are extremely, extremely tight. And she's had a huge amount of treatment from different physical therapists over time. And as is common with these patients, you find that they might have a little bit of a improvement for a day and a half, and then actually it doesn't last. Then they go back again, and they're back where they were when they started. So with her, what the SIRPA approach does is we look very, very much about what's going on at onset. So we really dig into the sort of the timeline, and people very often will say, well, I did a physical thing, it must be related to the physicality of what I was doing at the time. But actually we know that obviously after 3 to 6 months, it wasn't easily that healed, and we've now got a persistent sort of neural circuit pattern that needs to be retrained. And so with her, she, as I say, what we needed to treat really was the anxiety, and the sort of shortness of breath symptoms weren't related to the lungs, or the cardiac system, they were related to the anxiety. She was having sort of panic type attacks. And so what we did with her, as well as treating her to release the tissues, very gently to release off the muscles, to release the fascia, to allow everything to calm and settle, we're also thinking about doing that with an intention of calming the nervous system. That's the sort of the physical part of it, not necessarily, that's when we start to combine the SIRPA with the physical. And then we then started by teaching her sort of self-soothing techniques. So certain breathing techniques that are really calming. There's a havening technique where actually if you go across the body and you start to soothe the nervous system, almost like you would if you've got a small frightened child on your lap. Very, very simple, very small techniques to start to, as I say, to downregulate that sympathetic sort of response within the nervous system. And then what we do also, which is something that was new to me, is sort of teaching what we call somatic tracking. And somatic tracking is when you're taught to feel the pain, not to really feel it, but just to observe it, to watch it with curiosity, but to then dissociate the sort of the worried sense of feelings and thoughts that go with, oh my God, I've got my pain, I mustn't do that, I mustn't do this, I mustn't do that. It's teaching people to be able to feel their pain without the sort of, as I say, the stress response that goes with it. And that takes practice. But it is something
is that something like, I think it's a NOE approach, isn't it, about drawing your pain? You may not be familiar with it, but I've certainly heard a similar sort of thing described. It's not necessarily put in the same way, not sort of withdrawing yourself and looking at your pain from the outside, but it was drawing what your pain looks like. And I wonder if that's a similar sort of thing.
Oh no, yeah, no, this is really about feeling your pain, but learning to feel your pain safely. There's so much fear surrounding pain, understandably, completely understandably.
Yeah.
But that's the bit that we've got to take out, because essentially that's the bit that's making it persistent very often. The Neuro-Orthopedic Institute, NOI, they talk about DIMS and SIMS. DIMS are danger in me and SIMS are safety in me. And it is that sense of danger. Everything becomes a danger. They're particularly a sensitized nervous system.
Right.
Even loud noises can make a difference. So it's about deregulating that.